My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff, and incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay Hospital to refer their patients to high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic program called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this program, and we're the first organisation in the UK to roll this program out. The future for Ramsay Healthcare is bright both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsay, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.
Hi, good evening, everybody. Welcome to another lecture of distinction brought to you by BOFAS. My name's Graham Chooser. I'm a consultant in the northeast of England, and I have the privilege tonight of introducing Mr. Haroon Majeed, who's a consultant foot and ankle surgeon from Manchester, who will be delivering tonight's lecture on Hallux Rigidus. Now, the talk will be around 30 minutes long, after which we will have time for questions. As usual, please enter your questions in the Q&A box, which should be at the bottom of the screen and the little icon there. We'll try to get through as many questions as we can, but we'll need to move on to some cases that have been very thoughtfully prepared, which I'm sure will stimulate further discussion. And we will end tonight's session at 9 p.m. promptly. And we always look forward to your feedback on these sessions. Your feedback has been fundamental to making these lectures work so well. And as an incentive, you will only receive your CPD points and your certificate after providing this feedback. So we'll post the feedback code onto the chat function, again at the bottom of your screen. You'll also receive an automated email once you log out of tonight's broadcast. So I hope that all makes sense. I'll remind you at the end of the talk as well. So without further ado, please allow me to present Mr. Haroon Majeed.
Thank you, Graham. Good evening, everyone. Let me just start sharing my screen and then we can kick off. Right, so I would like to thank BOFAS Education Committee for sending me this honorable invitation. Over the next 30 minutes or so, I'm going to talk about Hallux Rigidus following this outline. Biomechanical studies have shown that first MTB joint plays a very important functional role during the gait cycle. Considering the small size of this joint and a very thin articular cartilage, it takes enormous amount of load with every single step. So if you combine the magnitude of thousands of steps that we take on daily basis, then this joint undoubtedly is taking a lot of force in our daily activities. And unsurprisingly, that results in the first MTPJ arthritis to be the second most commonest presentation in a typical foot and ankle clinic, only preceded by bunions. The incidence is far more common in females than in males. Majority of these cases are unilateral and may have a previous history of trauma. With increasing age, the incidence of arthritic MTPJ increases. The bilateral cases, they usually have a positive family history, once again, female gender, and may also have other associated pathologies of the big toe. In general, the other associated risk factors with the development of arthritis have been shown to be activities that result in repetitive stress, inflammatory and metabolic conditions, and certain anatomical variations that over a period of time result in overloading of this joint. Now, the shape of the head of the first metatarsal has also been associated with it, that if someone has a conical shape being shown in the right-sided picture compared to a spherical shape, that may also result in increased incidence of arthritis of this joint. In the literature and in common clinical practice, there are certain nomenclatures used for describing this condition, but it's important to differentiate the two commonest used terminologies: Hallux rigidus, which is the arthritic first MTP joint, and Hallux limitus, which actually is a functional pain due to soft tissue tightness. But in certain referral letters from primary care, you may also see this term mistakenly used by our colleagues. Hallux limitus may actually progress to hallux rigidus. A typical patient presents with pain and stiffness, being the two most common complaints. Pain can be present at rest or usually aggravates with certain activities that result in hyperdorsiflexion of the big toe. Certain shoes, in particular in female patients, may aggravate the symptoms, especially if they have narrow toe box. There may be some deformity present resultant from the previous history of trauma. Some patients may report numbness, which is because of the dorsomedial cutaneous nerve being directly under pressure from the osteophyte. You may notice features of generalized arthrosis in multiple other joints, or in patients with inflammatory arthropathy may have certain characteristics on inspection. So your examination of the foot will be focused on the forefoot, but you have to assess the rest of the mid, hind foot, and the ankle joint in detail. A typical patient will present with a visible or a palpable dorsal osteophyte of a variable size, which usually is tender locally. You have to be very careful in performing the range of motion because dorsiflexion will be limited and painful because of a direct contact of the dorsal osteophytes in the end range. The mid-range pain can be assessed with a very carefully done grind test without causing too much pain. And you may appreciate other associated deformities of the big toe and the lesser toes. On gait assessment, it is commonly observed that patients try and avoid weight bearing on the medial border. And you may notice plantar callosities along the lateral border, which are reflective of the overload phenomena over a period of time. It is important to assess the movements and pain arising from the IP joint as well, because if someone has coexistent IPJ arthritis, which fortunately is far less common than MTPJ, then you have to really think about the definitive options of fusion very carefully, because if you fuse both the joints, then patients will have a very stiff medial border, and in fact, the symptoms may get worse eventually. The usual way of assessment, as we all know, are weight-bearing AP, lateral and oblique radiographs, which show the usual features of a variable severity of arthritis, including narrowing of joint space, subcondylar sclerosis, cysts, and abundant osteophytes, in particular the dorsal osteophytes. CT or MRI scans are usually not required, but in certain cases, you may wish to investigate other associated pathologies, if there are other associated symptoms around the lesser toes. MRI may also help the assessment of the central articular cartilage, which may help in certain patients. Like everything else in orthopedics, there is a classification, and in fact, there have been 18 different classification systems described in the literature, but none of them meets the ideal gold standards because of lack of reliability and scientific validity. There is a general consensus that the classification system described by Coughlin and Chernas is as close to being a gold standard as can be achieved. I wouldn't go into the fine details of this, but basically the grading system ranges from minor symptoms on clinical presentation and the X-ray features. And if you combine these, then the symptoms as they progress and the radiological stages as they advance, then it can increase the grading of this disease. And these are certain X-rays representative of a mild to severe disease. Treatment, usually the first line is non-surgical, and that includes a combination of modalities of pain management. Anti-inflammatories are a reasonable choice if there are no contraindications. Certain modifications of shoe wear and activity may help the symptoms. Physiotherapy may help the overall proprioceptive response and the overall function. And some patients may feel better just by having some physiotherapy of the EHL and FHL, along with other modalities. Injections are fairly commonly used. Shoe wear modifications typically include a wider toe box with the addition of stiff rocker bottom type insole and Morton's type extension, which is a rigid extension under the first MTP joint and the big toe. The idea behind the use of these modifications is that it reduces the arc of motion, in particular the dorsal contact of the osteophytes, and that may offload the joint and limit symptoms to some extent. Certain studies have shown that the response of steroid injection is better in early to moderate disease, again, following the rule of common sense. It is expected the response of injection reduces with the advancement of the disease. However, in certain patients with advanced disease, you may be surprised that they do respond very well to these injections up to a certain time. So it is a reasonable option that can be recommended, preferably in early to moderate disease, but with caution and with counseling in advanced disease as well. Hyaluronic acid injections have also been tried, and this particular RCT compared steroids with HLA. Overall response was similar in improving the pain and function. However, the patients who received HLA injection, they had better gait assessment and a response to this compared to steroid, but only in the short term. Overall, a combination of non-surgical modalities of orthotics, shoe wear modifications, pain management, and injections, it achieves a reasonable response in just over half of these patients. So certainly worth considering prior to undertaking surgery. If and when the non-surgical treatments fail with persistent symptoms or progressive disease, then surgery comes into play. And the surgery can be either joint preserving or joint sacrificing. Among the joint preserving option, the primary option is cheilectomy, which can either be tried alone or combined with certain osteotomies to offload the joint. Mainly it's an open procedure, but some surgeons, they also practice minimally invasive techniques. Among the joint sacrificing, the gold standard, hence written in gold color, is fusion. But there are certain arthroplasty options available with some reservations. Keller's procedure has really become a historical procedure now, but still can be considered in some patients if the other options become less viable. So with surgical treatment, we are aiming for pain relief, maintaining and improving the stability of the medial column, and this in turn improves the overall function and quality of life on a day-to-day basis. However, you have to keep in mind that one size doesn't fit all. You have to individualize your treatment decisions based on patients' expectations, their physiological demands, and their motivation level. Cheilectomy is considered the treatment of choice for early to moderate disease if there is 50% or more joint space preserved, and if there is less than 50% articular cartilage loss. And hence the role of MRI can be important in these cases. You really have to excise about 20 to 30% of the dorsal metatarsal head, along with excision of circumferential osteophytes. If you excise more than 30%, you're likely to destabilize the joint. And if you do less than 20%, it may just prove to be a homeopathic surgery. So cheilectomy improves the overall range of motion, in particular, decompresses the dorsiflexion. That in turn improves the gait pattern and the push-off power. But you have to counsel the patient and explain clearly that this is not a definitive surgery. This is only an interim procedure to buy a few more years until the definitive surgery is required. And it doesn't really prevent the progression of the arthritis. In fact, in some patients, if the symptoms improve reasonably well after cheilectomy, they may be more inclined to do more physical activities that may actually progress the central disease fairly rapidly. So you have to be cautious in counseling the patient on cheilectomy. Within reasonable indication, there is good evidence available in the literature that in carefully selected patients, it achieves good to excellent results in over 90% patients in early to medium term follow-up. If you combine cheilectomy with a Moberg type dorsal closing wedge osteotomy of the proximal phalanx, that helps to decompress the joint even further. Some studies have compared cheilectomy versus combined procedure and have shown that combined procedure results in higher satisfaction rate and the overall outcomes. So once the disease progresses, or in cases of advanced disease with significant symptoms, fusion remains the gold standard treatment option. The different techniques described, including flat cuts, but more commonly in the current practice, ball and socket reamers are used because they help to control the three planes in a better way compared to flat cuts. And in certain advanced kits, I'm sure all of you have seen these reamers available. Once you prepare the joint surfaces, then there are multiple options available for fixation, ranging from traditionally and historically used cross screws, combination of dorsal plates, combination of oblique screws and dorsal plates, staples, and you can basically combine these depending on individual cases and your own preference and availability of implants. Studies have shown that the most stable implant combination biomechanically is an oblique screw with a dorsal plate fixation. So it is crucial to maintain the load-bearing capacity of the first ray and to minimize the risk of causing transfer metatarsalgia to the lesser toes. So you have to control your fixation in three planes, aiming for about 5 to 10 degrees of the valgus, about 10 to 15 degrees of dorsiflexion relative to the floor, or in other words, about 20 to 25 degrees of dorsiflexion in relation to the first metatarsal angle. And you have to prevent the occurrence of supination or pronation of the big toe. Intraoperatively, you have to check the simulated weight-bearing status by using a flat plate and aim for about 15 to 20 degrees of dorsiflexion of the big toe relevant to the ground level. No matter whichever implants you use out of these various fancy multicolored expensive plates, it doesn't really matter as long as you follow the principles of fixation and achieve a good result. So certain x-rays to highlight traditionally used cross screws, combination of screw and a plate, plate alone, and newer type of plates, which may have the option of cross screw built into those. So if you do the procedure well, follow the principles, there is good enough available evidence to suggest that you can achieve over 90% union rates, patient satisfaction, pain relief, and the functions. Like anything else, there are complications, but they are in acceptable limits, and you can roughly quote about 10% risk of non-union, which may go slightly up in smokers. So in terms of arthroplasty, there are options available, which include Silastics, ceramics, metallic, or the newer advanced cartilage implants. But you have to be very careful and cautious in using these in certain patients. I'll go through some details of each of these. Silastic implants are not really new. They have been practiced for the last 50 years, but sadly, in the early phase of their first and second generation single-stemmed and second generation double-stem implants, they got bad press in 80s and 90s. But if you select a patient carefully, and a typical ideal patient is minimum age of 55, relatively low demand, really neutral alignment, but you can accept under 10 degrees of valgus alignment, no previous infection, and the usual indications of any lower limb arthroplasty would stand here as well. If you do it well, it gives a good result in carefully selected patients, and patients in actual fact love this implant. I do this fairly oftenly. Without a biased opinion, I would still recommend to be used, but again with caution, not in everybody. And the reason why these implants got a bad press in early phase was that the surgeons really stretched out and went beyond their recommended indications, and hence the early failure rate was very high in those patients. The most recent publication is from Wrightington, with a follow-up of the average follow-up of 5.3 years and up to 97% implant survival, with good improvement of pain, function, and the overall satisfaction. Yes, there were revision rates, but within acceptable range, and minor complications in about a quarter of these patients. The most criticized problem with these implants was progressive osteolysis. However, it doesn't necessarily mean that the osteolysis is a result of these implants. There may be pre-existent cyst, which might have got progressed, but this study showed that about 1/5 of these patients had non-progressive and asymptomatic cysts on serial follow-up of radiographs. This is actually one of my own papers from a couple of years ago, because with so much good experience of these implants during my fellowship, I actually thought that why are these so much disliked? So I explored the literature and published this, including 28 studies which were available at that time. And the overall implant failure rate was 5.3%, which was actually significantly higher in the very first single stem generations, which were used in 1970. And then I also identified that the current third generation implants, which came up from 1997 onwards, there isn't any actual published study. They are fairly reasonably used, but I think surgeons may not be really brave enough to come out on the stage and present their results. But again, if you quantify the results, do it carefully within a very strict indication, they provide a reasonable outcome in over 80% of your patients. Now, the surface gets more slippery here when you talk about metallic and ceramic implants. The design was followed from total hip arthroplasty, but it actually failed very early and very quickly because of various reasons. Overall, the studies have shown high complication rates, and the literature suggests unpredictable, but probably they are more predictable. They are destined to fail because of radiolucency. Subsidence was very high, malalignment, soft tissue problems, and the usual failure for any joint arthroplasty was very high. An RCT that compared arthrodesis with arthroplasty showed almost half of these patients who underwent arthroplasty had radiological loosening at a very early stage, and 15% were revised at 2 years. And there are other studies available with shorter case series, and they have shown similar results. Ceramic implants were also used, and they have similar high failure rate in various studies. Hemiarthroplasty is also an option, but again, questionable results. So it can either be a hemiarthroplasty of the proximal phalanx or the first metatarsal. The only consistent study available is from the design surgeons from 90s, which showed good results. However, subsequent studies failed to provide good results in their patients, and their usage is very limited. Something more advanced, which has come up in the last few years, is Cartiva, which is a synthetic hydrogel polymer, basically the same material that is used for contact lenses. It is only about 8 or 10 millimeter implant that is inserted using a very specific technique into the metatarsal head and provides some spacer effect of offloading the joint. Its usage is getting relatively more common. I personally don't use it, but there are studies available to support its result. Early result was published in 2016 with 2 years follow-up and good results with improvement in pain and functional status. The same authors published their follow-up results in 2019 with overall almost 6 years follow-up and still maintaining a good functional and pain profile in these patients. Something more historical, but still an option as a last resort in certain patients if you want to utilize this. But basically, Keller's Excision arthroplasty destabilizes the first MTP joint, results in significant shortening and other associated deformities. So this covers the management of a typical case of an arthritic first MTP joint. I can go through some cases just to highlight, for example, a 70 years old male, medically fit and well, usual symptoms, and you can highlight conical shape of the first MTP, first metatarsal, which has been linked with Hallux rigidus in some cases. So again, the usual talk in the clinic, counseling of non-surgical and surgical treatment, and we agreed to trial an injection, which in fact surprisingly worked very well in this gentleman. Still reasonable effect maintained at about 6 months. He wanted to carry on, and by 12 months, he wanted to try another injection, which I gave only during the last few months, and he still doesn't wish to go for any definitive surgery. So again, injection is a reasonable option, and it may work well even in advanced cases. Another lady in late 60s, medically well, keen walker, but limited by arthritic first MTPJ and a moderate bunion deformity. So I fused her first MTPJ with cross screws, and she recovered very well with good improvement in her function and pain. This was interesting. A youngish lady with known rheumatoid arthritis came with pain around the first MTP joint as well as the second toe, and she was found to have chronic dislocation of her second MTPJ. So I fused her first MTP joint and performed the Stainsby's procedure. But when she came for her 3 months follow-up, she also reported pain in her third toe and found that this had also dislocated at some point early after her surgery. So now she's been listed for Stainsby's of the third as well. But she is doing very well with regards to her medial column. This was interesting. A 70 years old builder who retired only a couple of years prior to this presentation. He had long-standing history of painful big toes, both sides, and he was unable to make any ground contact with his big toe on this side. He also had bilateral calcaneal fracture when he fell off a scaffolding a few years ago, and that was also symptomatic, but to a lesser extent than his big toe. So this is what I did to him. Corrective fusion with some bone graft, which I don't commonly use in primary cases, but I had to because of the obvious reasons. And 6 weeks follow-up, he's almost pain-free and very happy with a good cosmetic as well as clinical result. Another lady in mid-60s, diabetic, typical bunion with arthritic first MTP joint and clinically painful grind test, hammertoes to second and third. And I did fuse her first MTP joint with a cross screw and a plate and straightened her second and third toes, and she's recovering well. So in summary, a common foot and ankle problem, which we see in foot and ankle clinic, conservative treatment is the first line and is successful in almost half of these patients for a certain time before they are ready for definitive surgery. Surgical treatment, you have to individualize for each patient as per their reported symptoms and their severity, their expectation level, and their physical demands of daily living. For mild to moderate cases, cheilectomy is a good option. If you combine with osteotomy, may improve your results, but you have to counsel the patient carefully that this is not a definitive surgery. For advanced cases with persistent symptoms, the gold standard remains the fusion with consistent results in pain and function, regardless of the choice of your implant. If you follow the principles well, you will achieve a reasonably good result. An arthroplasty can be an option, but very selected patient profile and very narrow indications. And you have to be realistic with the patient that this is not for life and they may require revision surgery in future. So I hope this gives you some food for thought about Hallux rigidus. And thank you very much for your attention and being here so late in the evening. I'm happy to take any questions. You can either ask now or send me through email later on as you wish. Thank you very much.
Thanks very much, Haroon, for an excellent talk. Very clear, beautiful slides, lovely diagrams.
Thank you.
We've got a couple of questions through. I wanted to go back, trying to think through this logically. If we start with injections, how do you pick your patients that you think would benefit from the injection, or are you just giving them some temporary pain relief? So, yeah, very good question. Basically, my usual talk is starting from doing nothing option, conservative options. And at some point during that, some patients pick up themselves because either they have had injections into their other joints. In elderly population, you commonly observe that they have hip or knee arthritis or shoulder pain, which responded very well to steroids. So some patients actually do ask for injections themselves. But in others where you feel that the joint is not really the end stage, it's moderate, symptom profile is moderate. So I then try and carefully just talk them through to injection. And if they agree, then I trial them. Some patients plainly refuse because either they have an injection in other joints or they know someone who had injection and they think it was waste of time. So in that case, I don't really convince them for injection. So basically, as you're talking through your treatment options, then probably I think some patients will opt themselves, or some you can carefully guide them towards injection. Okay, all right. Question from me about cheilectomy. How do you pick your winners? I've done several cheilectomies where I think this is perfect, take off that dorsal spur, and sometimes they come back worse almost straight away after the operation. How do you pick the ones that are going to win? That's true. It is a difficult decision. To be honest, I don't do that very oftenly. So far, I've done only a handful of cheilectomies over the last 3 years or so, and the choice can be very difficult. So once again, just following the basic rule of the joint space, relatively younger patients who may not be ready for a definitive surgery. And in those cases where I consider cheilectomy, I definitely do an MRI scan to assess the central joint surface before committing to cheilectomy. But yes, the results can be variable. So difficult one, but you have to very carefully select depending on the joint surface, depending on their age, and you have to counsel them about the activities that they may have to avoid even after cheilectomy. Okay. So we've got some questions here stimulating other questions. We've got one from Henry, says, how often do you give the steroid injections? I don't know if that means, do you do it every 3 months, or how many can you give before you decide on a definitive treatment?
So my rule of thumb is that not more than 3 injections over a lifetime of a joint. I can push for a 4th one in some cases if they're doing well and still don't want to go for definitive surgery because of the obvious reason we want to avoid any long-term steroids. How oftenly? So minimum gap 3 to 4 months, again as a rule of thumb, and trying to minimize their potential risks. So after an injection, I follow them after 3 months. If they're still doing well, I give them like a 6 months appointment to touch base again. If they're still doing fine, I just carry on their yearly follow-up or discharge them back to their GPs. If they wish to go ahead for a second injection, then by the time you have already spaced them out enough. So the simple answer to this question is not more than 3 injections over a lifetime of the joint, and space them out minimum 3 to 4 months. I
find these patients very good for telephone appointments. 3 months after the injection, it's either worked or it hasn't, and then you can decide to repeat it or do something more definitive.
That's right. Especially these are, good patients to be followed up over telephone during the last couple of years because of these circumstances.
Okay. I've got a very good political and topical question here. It's from Jonathan. It says, great talk, thank you. How does one begin to summarize all this information for patients in clinic, given the new Montgomery principles for consent? How do you give them all of this information and expect them to make a decision?
So very good question. Realistically, it is impossible, not only for Hallux rigidus, but even if you have any other condition, you can pick and choose, for example, ankle arthritis. So this is an ongoing debate between clinicians and the management that we are expected to consent the patient in clinic in 15 to 20 minute slot where we have to discuss, where we have to examine them, obviously after taking history, see their x-rays, guide them towards a reasonable decision, then write everything on papers and then dictate as well. So all of that takes easily half an hour slot. So yes, it is a well-known problem. So ideally we should have separate consent clinics. After we have listed the patient, then obviously with this time frame between the listing and the surgery in the last year has been enormous. So the consent forms have been really outdated as well. So ideally, we need a separate consent clinic where we can spend 10 or 15 minutes time going through these options again. But in a typical clinic, it is really difficult to go through everything and these options in 15 minutes. So you have to find your own ways of managing the time and just keeping your talk to the point and very relevant as well. So there's no easy answer.
Do you use any patient information leaflets to help provide that information for the patient?
So in Wrightington, we did have. In the current place, they are in the progress. So we haven't really printed them out as yet. The work is being done in the background and hopefully we'll have some leaflets available. I do have my own website, but I don't refer NHS patients to that website because of the obvious ethical reasons. But in the private sector, I can refer them with the permission of the place where I work.
Well, hopefully in due course, BOFAS will have a comprehensive range of these leaflets on their website, which may well help this kind of situation.
Very true, yeah.
So another good question here. How would you manage the 45-year-old runner with symptomatic Hallux rigidus who still wants to run? And the second part of that question is, what changes, especially in push-off strength and athletic performance, are expected?
So again, a very tough call to make. You have to be very realistic with your patients that their running days might actually be running over when they develop such a symptomatic and severe arthritic disease in their big toes. But some studies have shown that functionally, in one of these slides, you might have picked up that one of the studies showed that after fusion, a reasonable percentage actually return to sports. So if it comes to a stage where a runner wishes to undergo definitive surgery, my default choice will still be fusion. but again, with reservations that they may not go back to their pre-surgery level or pre-symptomatic level. So as long as they accept the limitation and are willing to take a chance, then yes. Otherwise, they have to really cut down their significant sporting activities.
Do you ever find these patients who are limited in what they want to do by pain, disability, if you take their pain away and give them a stable medial ray, some of them might actually improve?
Yes, true, they may, because essentially you are converting a stiff and a painful joint to a more stiff but hopefully pain-free joint. So their activity level and the overall function, when they compare pre-surgery to post-surgery, majority of the patients, they do report a good outcome based on that reason and their own comparison of subjective symptoms. So yes, yeah.
So that last question leads me nicely into a very difficult situation. What happens when this chap comes back at 55? He's had a great fusion of his first MTP joint, and he's now got painful arthritis of the IP joint.
Yes. So to be honest, I don't know the correct answer. I don't think anybody knows, but there have been, during my fellowship, there were a couple of such cases who previously had fusion of the MTP joint, and they had symptomatic progression of their IP joint. So then those patients underwent, not by me, but by obviously the team looking after them, they underwent taking down of their fusion of the first MTPJ, conversion to a Silastic joint as a stage 1. And once they had recovered, then a fusion of the IP joint so that the medial column doesn't become too stiff, and at least there is some movement regained in the MTPJ, and then you can fuse the IPJ. So there were only 2 cases. I don't know, to be honest, how did they do afterwards, but theoretically, yes, it is an option, but again, a very difficult one to take, and you have to once again counsel the patient very carefully.
Are you aware of any cases or any experience of using a Silastic implant for the IP joint in these cases?
No, to my knowledge, I haven't seen, and I'm not aware if any option is available. Okay,
all right. So while we're on the subject of Silastic, do you use the grommets, the little metal sleeves that you showed in those pictures?
So again, if it comes to a point where I get an opportunity, I would spend the whole session on Silastics and spend time on praising them. But there is a history behind the use of grommets as well. So they were developed in 90s to minimize the contact with sharp bone ends, because that was considered a potential reason why the osteolysis can start if the implant itself can get damaged because of the sharp bone ends. So to protect that effect, these titanium grommets were developed and started to be used. But in actual fact, the studies show that these metal grommets cause more detrimental effect on the implant themselves, and they resulted in more osteolysis. So then the usage of these grommets has really gone down. They still come packed with those implants, but I don't use it because of the same reason. And the way I've been trained, it is better to avoid using them and use the implant as it is.
Okay, there's another question about implants. Someone anonymous, which is concerning. Are surgeons using these implants? I don't know if it's referring to Silastic or the hemiarthroplasties or joint replacements. Are surgeons using these implants using a joint registry or equivalent?
I don't think they are. Maybe subjectively some are using, but there is no requirement as hip, knee, or ankle replacement, because ankle replacement is on the registry now. So I'm not aware of the MTP joint replacements being on the registry.
Okay.
So I don't think anybody is using them, but I think they should. It's a good suggestion.
Okay. So I think most of the discussion here is about fusion. We often do fusions as salvage for severe hallux valgus, or even previous hallux valgus surgery that has now failed or been unacceptable. So in these cases, sometimes we have to shorten the first metatarsal. How much shortening is acceptable before we need to think about putting an interposition graft in there?
So again, I think you have to assess individual patients. For complex and revision cases, I may use X-rays. I don't normally use X-rays for a standard primary fusion. Some surgeons do use it, but obviously there are merits and pros and cons for these. But for a complex case, for example, the one I showed, which had ankylosed joint, I did use X-rays just to guide myself because I was concerned about exactly the same reason. I may end up shortening the big toe. So you have to really objectively assess on table as well as on X-rays in order to maintain a reasonable profile of all the toes in relation to obviously the second toe, but you can assess your own clinically as well as on X-rays in that particular case.
Would you use iliac crest bone graft to provide length if you needed it, or is it another suitable alternative?
Yes, that's the most common one. If I have to use, because again, that gives you a reasonable length for revision cases, or in cases where, if you're revising from a previously failed Silastic, for example, then that is the standard choice, which I would use.
How do you deal with infected? I know you never get any infections or complications, but how would you deal with an infected Silastic if you had to? You know, one that had been referred in from elsewhere, for example.
Yeah. So again, well, no, nobody is exempt. So complications occur to everybody. So again, the standard principles of infected arthroplasty, you have to assess the patient clinically, inflammatory markers, aspirate, CT, and so on. So you have to really analyze and differentiate between aseptic loosening and infection. And same principles are followed. Again, microbiology advice based on samples. Take out the implant as first stage. That's what I would do if I'm in that situation. And in that case, probably you may not need to do much, because if it's a relatively low demand person, what the Silastic is doing is working as a spacer. So it's a modification of Keller's in reality. So in that situation, if you take out the implant, find the organism, treat the infection, and if the patient is doing well with the Keller's type arrangement, then you may not need to do anything more after that. If infection improves with time, cures, patient has issues with that type of setup, then the only next option I would do is, again, a bone block fusion and use a plate, but very cautiously again.
You don't use any antibiotic substitutes at the time of surgery, at the time of implant removal?
So again, so far, I haven't been in that situation. But again, that is an option I would keep in mind if I have to use it, following the same principles of treating an infected arthroplasty.
Okay, all right. We've got another question about surgical tips here. How do you get through tough subchondral bone to prepare the joint surfaces?
Is that for Silastic or for fusion?
Sorry, that's for fusion. That's for fusion.
So ball and socket reamers, usually the bone is not that hard in that area. It's mostly cancellous, but in some cases, in the previous builders and so on, the bone can be tough, but reamers are fairly sharp, and I have not had any issues to prepare the bone using those sharp reamers.
Okay. Do you supplement that with drill holes or K-wires?
Yeah, always.
Yeah.
Mm-hmm.
Yeah. Okay, fine. We've got no further questions from the delegates, unless any more come through in the next couple of minutes. I think I know the answer to my final question, which is what's your preferred option for dealing with first MTP joint arthritis?
So again, my default choice in a typical patient, without any obvious other reasons to contradict this, I would go for fusion. But if I find a suitable person based on a very strict criteria, I would consider Silastic as my second choice, but nothing else really. I don't use Cartiva so far. Things may change in future, you never know. And Cheilectomy is obviously on its own merits, but I have done only just a handful of these so far in very carefully selected patients. So default choice, fusion. And if a suitable patient is there, then I would do a Silastic.
So that's your personal preference. If you had any advice for people going towards the exam as to the gold standard treatment for first MTB arthritis, do you have any advice for them?
I don't think you can be criticized for saying fusion as your standard single choice. There is sufficient evidence available in the literature that it remains the gold standard. So I would suggest just using fusion as their standard answer, as long as they are aware of the 3D plane correction, stabilization, regardless of the choice of any specific implant. They have to give a generic answer of fusion using either cross screws or plate or a combination, and aim for that specific position that they have to maintain. So I see no issues with that answer.
Okay, thanks very much. There are no further questions that have come through. I realise we've still got 8 minutes left, but I don't want to sit here in silence. Do you have any further points or comments you'd like to make before we close the session?
No, I think we have discussed in a lot of detail, and there were really good questions. Thank you very much, everyone, for your time so late in the evening, and all the best with everything. Okay.
Well, thank you. I'd very much like to thank our speaker, Mr. Haroon Majeed, for his excellent, inspiring talk. It's bread and butter stuff to most of us, but when we go into all the detail, it actually becomes quite interesting. You can see from the questions stimulated a lot of discussion. I'd also like to thank tonight's sponsor, Ramsay Healthcare. And finally, a reminder to submit your feedback using the code that you've hopefully seen in the chat box here. So use that to submit your feedback, or use the email that you should get once you've logged off. Once you've done that, you'll get your attendance certificate and CPD. The last thing I'd like to do is remind you and invite you to next week's lecture of distinction on pediatric foot deformity by Mr. Krishna Bemulapalli from Romford. But this will be next Tuesday evening, January the 25th. So I'm going to wrap it up there. I hope to see you all next week, and I wish you all a very good night.
My name is Andy Jones. I'm the CEO of Ramsay here in the UK. Ramsay Healthcare is a global provider of healthcare. We operate in 11 countries, employing 77,000 staff. And incredibly, we look after over 8 million patients a year. Ramsay Healthcare has been here in the UK for the last 12 years. We've now become the #1 provider for NHS services, which means that GPs are able to choose Ramsay hospitals to refer their patients for high quality healthcare. So Ramsay has got a long-standing set of values called the Ramsay Way. They really define who we are as an organisation, how we work together, how we look after patients, and ultimately it's all about people caring for people. We're very proud of the services that we provide, and that's largely due to teamwork and our staff. The difference that this makes for patients is really high quality healthcare in all of our hospitals and facilities. We've got an absolutely fantastic program called Speaking Up for Safety. It's all about training staff to be positive and to call out episodes in patients' care, particularly when they're concerned that things aren't going right. We've been able to grab this program, and we're the first organisation in the UK to roll this program out. The future for Ramsay Healthcare is bright, both globally and for us here in the UK. All of our units are accredited for endoscopy. The Care Quality Commission has rated 92% of our hospitals as good, and 95% of our patients would recommend us to their friends and family. We're a leader in day case surgery. We've looked at the way that our hospitals are designed so that we can treat ever more patients in today's healthcare. The future of healthcare is all about partnerships and integrating the patient journey. At Ramsey, this means we need to be working very closely with all our partners, including the NHS, to make sure that our services are available in all the communities that our hospitals serve. Over time, I can see the company both growing and expanding in the reach of its services. But for me, most of all, patient safety and quality come first. Simply put, people caring for people.